So don't try to skip. Just try to answer. You answer is at the right. That side also you can put down.
Anna.
So can you have the slides?
Thanks,
Which one's whichever makes sense.
So yes, this is basically some order. You can just some of them.
No, Anna called for some.
When you answer, you know, given also
Anna called.
or ECG or also don't try to jump into an answer and complicate it. Most of the time will be wrong. So then the whole thing will go. Then the examiner will have to go back and so start discussing the pricing or image or whatever. It's an X-ray start with the view, like that you start. Then at least you will get some points. Otherwise you jump into the answer and then it is done. That is the truth. And the examiner will also have some ego. If you try to answer the first time, he will also think that, oh, this alone is so smart. So answer step by step. Okay. So, you can proceed, but can have the lights now. It's also
Yeah, but
so this is an X-ray of the post-operative child. You see better with this
all the screens see.
Yeah.
I can send you. I don't have
The
super.
X-ray of the post-operative, it's a little difficult one. I think many of you have been right. The post-operative patient who had two surgeries
Yes, and I have.
done. Yeah. Two surgeries done for one particular condition and they developed a complication subsequent to that. And this is the treatment done for that. What is that? Who's are in the mic? Yeah, this is the person. You can sit there and answer, don't identify who you are. Try to answer. I gave it a clue. A child who had undergone two stage surgery and developed a complication. And now one intervention is done for that. Actually, two interventions are there in that screen. Okay, good. One that. What is that called? Complication developing after a fondant. The fondant failure. The fondant failure. So what is that? What is that? Clue in the what is that? Thoracic tract. Embolization is done. And what also is there? There is an ICD clue. No? The patient had significant poor respiration and thoracic tract ligation also. Okay. Again, similar. Next person. Yeah, go on, try discuss what it is. So, where is the catheter coming from? The pictorial angiogram, the catheter is coming from the tubular, it is being injected into the SPC. Yeah, don't discuss it. Yeah, what is filling? For SPC, usually when we inject what will fill? RF, but here we see RF. What is filling? Phase. And then you are seeing the external wires also. The post-operative patient. So what is it? It can be
See, 45 minutes like limit of operational. Just
so one more finding is there. You can see some other finding is also that somebody can point out. There is a trend in the you have a point. There is something here also. There is an ambiguity trend also. There is an ambiguity trend violation that subsequently the patient underwent okay. So they will be asked what is the pressure where you recommend the patient for a completion of one time. All those things. Okay, next person. Yeah. The patient underwent a surgery in childhood, and now the patient, the person suffering with surgery done in 1990 or something in our institute. Yeah, you can start describing. What is it? What is it? What is the imaging? No, okay. Yeah.
3D reconstruction of analysis.
Very good. Because there was no CT I have forgot. It's very reconstruction. Okay. You got 20 marks. 20 marks. That is how. Otherwise, yeah, go on answering. Yeah.
Archaeopteryx appears in
Archaeopteryx. So, what is the most common condition? Coarse. And what surgery is done for that? The bone segment is still there, but something else is done. So see here, no? This is the coarse and something is done from here to here. What is this? It's called jump graph. Jump graph for coarse. Okay. Not very rare. I have not seen such a good image for this. Okay, next person. Yeah. So, what describe it? The condition coming from where? Immoral artery to ascending aorta to one ventricle. So one ventricle, you don't know whether it is healthy. Is it a morphology or an RV morphology? It is an RV morphology. Because it is closely related. And do you see a coronary? The coronary goes with the ventricles, no? So what is this coronary seen here? This is the circumflex, this is the iliac. So this ventricle is the left ventricle. So what the condition is in the right. So right ventricle is given rise to the aorta. So what is the condition? And what else is there? Is the usual aortic angio, do you see? How is it seen? This whole, the whole aorta is one thing? Yes, sir. Right? No, right side. No, left side. What is the clinical finding in this patient? Do you see a problem in aortic pulsation? This is what is the well-forced aorta in CCT. Okay. Well-forced aorta in CCT. Okay. So the condition is the RV morphology respect to give rise to aorta. This is another example of the same.
You
But what else
gave
is
that
there?
pacemaker STM photo. You got it with your thing.
Another example. Same well-forced aorta.
No. New one. We talked. Okay, leave that. Later, I'll see. Later you go. Now you
Okay,
take
next
PVC
one.
book and go to Mayur and Arun.
Wrong answer, yeah. What are they saying? Even I can multiply your patient. Yeah.
Yeah, okay. You have your first book. You have it. Yeah. I said Mayur sir wrong.
Very good.
Oh.
Upside is, I think we are reading book. Okay. It's if it is a radial route or somewhere else? Jugular route, it is coming to the army. Right well. Right well. Communication between the aorta and right ventricle. Not aorta and right ventricle. What is seen here? What is this area? This white area. That is the interventricular structure. So what is the connection between interventricular structure? What is it? This patient had a chest pain some time back and an MI. So it's actually a case of a DSR. What is this device? It's a muscular related device that you should know what the device is made of. What are the devices made of? What is the regularity of making out? Tape member alloy. It's nickel, titanium, and oil. Okay. You can see it. Yeah. Okay. First see the ECG, then see the X-ray. Who is driving the right? Yeah. The basic problem. Okay. So what is the ECG first?
ECG shows T-inversion to TPA and lateral wave.
Okay, but that doesn't matter. It's relevant the rhythm. Now we are looking at the pacing.
Little pacing.
Are you seeing the
Little
pacing spikes?
Painful.
Pacing spikes are there. Is it pacing?
No,
Failure to be
Is it sensing?
no.
not nice.
It's sensing, not sense. It's sensing. But it is not pacing. So now there is a problem with the system. Whether it is the pacemaker or it could be the lead. But there is pacing the pacemaker and the battery may be okay. But what could be the problem? Could be the lead. So look at it. What are the indicators of
Lead fracture.
Are the both leads working or is it only a single lead which is
RLA is basically.
No, it is not distinct. So the apical placement, you know, mostly we see the circle placement. That is why you should it is abnormal. But previously we used to do all apical placement. Okay? So both leads are working. Both leads are there, but one of them is connected. Here, that is not connected. Okay? But what is abnormality? The one which is connected has some abnormality. What is abnormality?
Lead fracture.
You see very closely forward. What is here? The fracture of the lead. And what are these two types of leads? Is there any difference between the two types of leads? Screwing and no. Right? What is the difference in thickness? What is the difference in thickness of the two leads? The one which is pacing and the fracture has the thick lead. So thick lead we have. What is the thickness and what does it mean? Bipolar versus unipolar. Bipolar we have both the poles of the receptor. Okay. Okay. Next, who is there in the mic? Yeah.
MS.
Sir, I will give you the LV and then LF training. Yeah.
MS.
This is to drive one point. If you look at the hemodynamic tracing, you should look at something else.
Higher hoops.
Yeah, tell us something. What is the LVD? What is the electronuclear endocrine pressure? Where will you find?
Peak of our
So what is the sinus beat here? This is the sinus beat here. This is the only sinus beat. Okay. So there is a P wave, but what is happening here? What is happening to the wave here? So this is the atrial contraction is happening on the
Ventricle.
so this is the only sinus wave. It's a retrograde wave producing a what wave? Cannon. So what is a regular cannon? What are the reasons for cannons? That you should learn. Okay, this is an 8-year-old boy with the effort endurance, recently detected heart disease. Okay, so we can discuss. Who's having the mic? Who's having the mic? It's disappeared. Oh, okay. Yeah. They don't take pictures. Whether you take only pictures, you don't listen. Yeah. Yeah, start with the calculation. If the efficiency calculation normal, 65 to 75 is normal. Is the RN normal, RV normal, PA normal. All right side of calculation between 65 and 75 is normal. Okay. So is there a step up? There is no step up. Left hand calculation is a normal. The paper is normal, ascending average is normal, what is abnormal?
FA.
All there is a desaturation. Okay. Now come to the pressure. RV is 8. Is it normal? Slightly elevated. RV is 8. It's both the systemic. RV is 105. Is there a PS? no PS. What is there? It's PA. PS, no PS. LA means normal, aortic pressure normal. So what is the abnormality? Severe pulmonary arterial hypertension. Okay. And what is the other two in this? Pulmonary artery desaturation. What is the condition where you get a very high, almost systemic PA pressure with a descending aortic desaturation alone? The PDI. Okay. That is how you will assess. Okay. You should know what is when the PA saturation is equal to aorta, PA saturation more than aorta. You all know that. I think you know that. Okay. Next one. Who's on the mic? Yeah.
It takes a picture from the pulmonary vein. Yes.
Where is the detailed condition?
Pericardium.
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 This is the pericardium. So pericardium means put cardiac to the femoral vein.
No, this is the.
So that
This is the.
subcaral area we put a detail. Why it is one
Effusion.
pericardial effusion. You can see the movement of the heart. Now that right thing is moving, outside it is not moving. And why it is done? Why the pericardial effusion has happened?
Boost device ASD. Septal
What is
culture.
that hardware name? Anybody can recognize?
They attempted the EA's function.
So what is that hardware inside? The PTLC below. I know below. So it is a we recognize only the effusion after doing the BMP. So what in this situation, what will you do? You take out the balloon catheter or retain it there?
Retain.
Always retain it. Yes, because it may be a stitch phenomenon where you have gone through the pericardium and entered the LA. So, if possible, you do the BME as rarely as fast as possible. Then, because it will reduce the LA pressure, so it will reduce the leak to some extent. If not possible, you keep the catheter there and call the surgeon or try to aspirate and it will set it. Within setting, stitch phenomenon mostly you will prepare a surgical. Okay, again this one. Who's are the mic? Yeah. What is the first half and what is the second half? And what does it, what is the hemodynamic phenomenon which is indicated here?
Yeah, but there is some rhythm of the period cycle of.
Rhythm of normality? I'm saying it is being paid. So on space and what is the blood pressure?
140 and 40.
No, in the initial half, when it is being paid. Is it a ventricular pacing or a atrial pacing? The ventricular pacing, no? Because it is broad, no previous. The ventricular pacing, the blood pressure is low, around 100 systolic. But when the sinus rhythm recovers, what happens? Why that discrepancy or the atrial contribution to the cardiac output? Okay, this is just one question. Okay, yeah, next person. Don't skip, next person. Yeah. No, extracardial will always come with some other adjective also, always.
Situs inversus.
Situs and the position of the heart is not together. Is it situs origin, situs inversus?
Situs inversus.
Which may have a complex heart disease, situs origin extracardial, situs inversus extracardial. Origin will have more severe heart disease. Okay. What else is there? Situs origin extracardial. What other points will you look at for situs? Mr. Gas problem just now. What is it? Diaphragm. Okay. Then
Bronchial infarction.
bronchial. Okay. Which bronchus will be straighter and broader? Right side. Right side. And clinical examination, any other point in male?
Front of largest.
Yeah, in males, any physical finding can help. Position of the testicular position. No? The testis will be usually lower. The kidney is lower. Right kidney is lower. Left testis is lower. Clinical, somebody may ask you. Small support for this very, very small point. But what else is there? So the cardiomegaly. Cardiomegaly. If the pulmonary blood flow increase or decrease?
Increase.
Increase. That's evidenced by the dilated pulmonary arteries, endothelial vessels, all those. Okay. If the pulmonary artery dilated, so pulmonary artery locally dilated, now you can see. Okay. Cardiomegaly, pulmonary artery dilated, plethora, probably some peripheral decreased pulmonary vascularity. But what is the most likely diagnosis? The conjunctival disease. What is the most likely diagnosis? After not just what are the most common pre-conjunctival diseases which usually come across?
Yes,
Yeah, what are the pre-common conjunctival diseases? Your answer.
so ventricular septal defect.
PST, AST, and PDA. Out of this, which is most likely in this case? Significant cardiomegaly with such a prominent pulmonary artery. I think AST should be considered in this case rather than VST. Okay. Okay. Yeah. Next person. Where is the catheter position? Catheter is coming from the
Femoral vein.
okay. Femoral vein and
Femoral vein going into left pulmonary artery.
good. Then
The contrast is
what type of catheter we use for certain angiogram, end hole, side hole?
end hole.
What we use for angiogram?
Multipurpose.
Yeah. Because we have an end hole and side hole or only end hole?
Side hole.
Always angiogram is preferred with the usually side hole condition. Okay. Yeah. Okay. So what is happening to the pulmonary artery when it is injected to the left pulmonary, lower pulmonary artery? What is happening?
There's a fistula between pulmonary artery to
A fistula or fistula or fistulae?
multiple fistula.
Yeah, it's a diffuse type of pulmonary arterial venous. Okay. It's immediately filling the. And what is this structure? When something is filling here, this area, you remove the. What is that?
PDA.
Left atrial appendage.
Left leg. Okay, that is the position of the left leg. Okay. It's a lady who is a long-standing some heart disease on follow-up for many years.
Last pulmonary trunk.
No, start with the, no, it will off the points. So that is good. Start with the 10 mark points. Okay. The X-ray CA view, if the exposure adequate, all those things you start telling you, you will get some time to think. First start with cardiomegaly. First start the bony cage and all, no? Position, bony cage. All those things, if you go systematically, the examiner will also be impressed that you are going systematically, even if you, the final diagnosis is wrong. Particular behavior, position is okay. Then exposure, bony cage looks normal. Then cardiomegaly is there. Okay. So which all chambers are enlarged? RA is enlarged.
LA is enlarged.
LA is enlarged.
Pulmonary arteries are enlarged.
Pulmonary arteries are enlarged.
Both we can do.
Okay.
LA.
The long-standing patient who is having PND or apnea and all, recommend PND. Long-standing disease. What are these travels? The recurrent pulmonary matter. But what are those white shadows? Mostly in the lower half of the lung. Yes, I said no, I gave so many clues. Recurrent pulmonary edema like things, most of here. This pulmonary hemocirrhosis, very rare, long cancer. Okay, next. Mitral. Yeah, it is mitral stenosis. It's a long-standing mitral.
If they will never get a chance to see.
Yeah, they will not see it. Yeah, so what is it?
It's a X-ray.
Yes, yes. Next, who's having the mic? Yeah. This is a typical X-ray. The typical X-ray of something. Okay.
Just check with the PAG.
Very good.
Still fast tissue bone related normal.
Okay.
Adequate exposure.
Very good. This is how you should answer. Then the examiner, even if you make very gross mistakes, also knowing that you are going systematically. That gives some point. Okay. Is it what is the site?
It is solid.
Site response. Okay. Especially when it's a congenital disease type of X-ray, you should always start with the site response. Then.
Narrow pedicle.
Okay. Yeah. So what about the pulmonary base?
Pulmonary.
What about the pulmonary vascularity? Normal, reduced or more?
Increased pulmonary.
Increased pulmonary vascularity. You are not seeing the pulmonary vascularity at all here. No.
Pulmonary is empty.
Yes, empty. And what about the pulmonary vascularity? Both sides significantly lower. Okay. Some condition with a reduced
Pulmonary.
And in that condition, you should always look at the heart. How will you look at how will you identify the heart? No. Who's answering? Yeah.
But the indentation of the trachea.
Indentation. It will be, I don't know whether it's clear, but it will be just above the bifurcation you see indentation. So, it is a right arch with a decreased pulmonary blood flow. What is the most likely condition?
Pathology of palm.
Pathology of pulmonary artery failure. And you should know what is the condition associated with right arch, which is the most common association, which is the most common association, or which condition associated with the highest percentage of right arch. Read that, read all those. Next person.
After students
Optical coherence geometry.
Okay. OCT or not?
I'm not feeling no problem.
Yes.
We go.
Yes, no, telling something.
Sir, there is.
Yes, sir. 25 minutes over.
Okay. Okay, yeah, please.
Critical section.
Everything in? The corona image, no? The corona image. The probably intervention is being planned or done or something. So what are you seeing inside the corona image? You are seeing some boxes, no? What are those boxes? Do you routinely put boxes in the corona or not?
No.
What is that? Already put. So something good is being planned. What is that? Biovascular scaffold. Okay, the biovascular. What is the thickness of this? What is the case when that Abbott biovascular scaffold was there? What was the thickness of the biovascular scaffold? 140 micron. Now what is the one which is available in India? What is the thickness? This one there is 100. So this is 100 micron. Okay. What is the normal thickness of a stent? Wait. What is the normal thickness? Usually coronary stent.
80 to 90.
Yeah. Some people have even 60 also. 60 to 90 you can say. Okay. So what is happening? This is a coronary biovascular scaffold is being implanted. I agree. But anything else is there. What is it done for? Does the coronary biovascular support produce shadows? There's no metal, no? What is it made of, this biovascular support? Polymers, mostly PLLA and PLGA, polylactic acid and polylglycolic acid. These are the two materials which is used for the bioabsorbable polymer. Okay, so what is it done for? Usually they don't produce shadows, but you are seeing shadows, no? But why are you seeing shadows? It's done for a old ISR, okay? So that's why you are having shadows in the background. Or you can see that invisible hyperplasia also, no? The shadows are little bit inside. And you can see the invisible hyperplasia. Over that, you have placed a dilator and placed a biovascular cover. Okay. Yes. Next. Next, you have yeah. What are the hemodynamic abnormalities in this patient? What are the tracings then? What are the three types of hemodynamic tracings you can obtain? One is ventricular tracing. Okay, then ventricular tracing, what is the peculiarity? To put it very simple, so that's zero. Okay, it is a single wave per cardiac cycle. If it doesn't touch zero, single wave per cardiac cycle is an arterial tracing. This is to make it very simple. It may not be coming all the time. Atrial type of waveforms, we have two waves per cardiac minimum. Okay, so what are the atrial type of tracings? Yes, RALA and one more. Pulmonary capillary well, which indicates indirectly the left atrial. Okay, so here you are seeing three types of all the three types of tracings you are seeing here. One is the right one is the ventricular tracing. What is the left ventricle or right ventricle? Left ventricle. It is written there. Mostly it will be written. You closely see it will be written there. Otherwise, so mostly it is 140 or something. Mostly it will be. And the other clue is that for the LV tracing, what will be the shape of the LV tracing? Notching. Not notching. It will be a rectangular. The RV will be triangular. Why is it so? The dP by dt. dP by dt. So which is more? Read about it. Okay. So what is it? So this is the left ventricular tracing, and this is the aortic tracing. Okay. And this is the left ventricle, the catheter is being pulled back into some other chamber. Okay. So these are the three. So what are the hemodynamic abnormalities in this patient? What is the LA pressure? What is the LV pressure? 140. What is the aortic pressure? 110. So what is the? There is a gradient of 30 between
LV and IR.
LV. So there is an LVOT obstruction. Probably by disease. And what is there in the lower panel, lower area? The catheter is pulled back from the LV to the LV is one of the atrial chamber. What can the usual from LV where can you pull it to the atrial? LA. So LV to LA. So what is the LV mean? LA mean here?
20.
It's around 20. Is it normal? Anyway, what is the LVED approximately? It's almost 1 or 2, no? Very low. So LV gradient, LA means 20, LVED is around 2 or 3 or 4 or 5. So there is a 10 to 12 gradients between LVED and LA. So what is the hemodynamic abnormality? Mitral valve, stenosis. And there is one more hemodynamic finding here. If somebody tells that yeah, that's what. That's what. I would. That otherwise I was asking you to give a prize to the person for telling that. Okay. So what is the Brad say that when the catheter is pulled back from the LV to the LA, what happens to the aortic pressure? Increase. Why? So Caraballo is the aortic, no? When you are cutting to take off the aorta. So here what happens? You are got a mitral stenosis, significant mitral stenosis. Your cathete was obstructing the flow across the mitral valve. Then your cathete was pulled out. You can see the aortic pressure rise. Okay, that is the phenomenon. That is the mitral equivalent of a Caraballo. Okay. Who is having the mic? Yeah. I think everybody is doing it daily. I think just you should answer. What is the bifurcation stent procedure? In your congenital heart disease, they will say they are not exposed. So this you can answer. Yeah. Just go on describing, then you will get the answer. Bifurcation stenting. Yeah.
Center is the main branch,
Center is very good. Center is the main branch. Then
side branch center.
side branch center. Then correct. Side branch. What is the third C? What is C? Huh? What is where it is not what? No, what is alone is there? It is crushed. The side branch is crushed. So who is that? Who is that? Next mic to him. Who answered that? Yeah. If you shout out the answer, the next mic will come to that person. Okay. Is it a reverse crush or inverse crush? This is reverse crush. Inverse crush is rarely done when the main branch stem is crushed. It's a side branch stem. Okay. This is reverse crush. Okay, next. Who is that? Who answered that? Okay, leave it. Okay, next person. Yeah. Yeah. What are the three processes and what are those?
5 minutes.
All page.
What ball and cage? What is that ball? What is that ball? Yes. Ball and cage, you know only one ball, no? But there were a few before. What is that ball called? Joke. Okay, is it a mitral or an aortic position? Why mitral? What are the two characteristics to identify a mitral cavity? There will be four struts, and the position will be opening towards the ventricle. These are the two characteristics you should identify to say that the mitral aortic will have a three struts. Okay, and what is the other processes? Other two processes. What is here? But the bileaflet valve. Bileaflet valve, in which position it is? Aortic position. And what is here? Annular. Is it a complete ring or an incomplete ring? To know what are the types of annuloplasty rings, it's an incomplete ring for a bicuspid valve. What is the etiology most likely? What is the clue for that? Multiple valves. One more clue is there. What is the here? Lot of calcium in the left atrial region. When indicate. Who's having the next mic? Who's having the yes? No, first read the what is the written there? 23-year-old female with a recent onset palliative technology. That is it. That's the important clue. Okay. Yeah. Now start reading. SVC is a normal.
Yes, sir.
Normal. Okay. Then.
Step up at 8 level SOCQ value.
Is it significant?
Yes, sir.
Yeah. So what you say what percentage is required? So you know that. I'm not going to clear it, but yeah.
Then R8 to RV not significant. Not significant.
Okay, leave it. Yeah.
5.
Probably you are taking at the point where it is something. Leave it. So assume that starting is okay. RV is okay. PA no further step up.
Yes, sir.
Okay. Then left side circulations are all okay?
Yes, sir.
They are all normal.
Yes.
So what is the oximetry finding you have? Hypoparathyroid air trail level. Okay, now you go to the pressure.
Harikrishna's, mid-raise,
Madhav sir.
Now significantly raised. What is it? Yeah. RFL is raised. RV?
RVD is raised,
RVD is raised.
Yeah.
RV pressure is also
raised.
raised. Okay. What is the, when you say about PA pressure? When you say about PA?
Me more than 20.
You should know about what is, diastolic pulmonary gradient, DPG, DPG, all those things you should know. Okay, I'm not going to those details. Okay, LM mean is slightly on the higher side. Then,
Vibrations are also raised in that.
right, okay. Yeah,
ASD,
AFP. 23-year-old, why should we have,
AFP.
critical onset palpitation and dyspnea, why should we have 23-year-old? No, who is answer, who has finished really that? I definitely should go to that sort of good answer. What is the other two? What is the other two? What is the aortic diastolic pressure? It is not normal, no? That's a significant diastolic runoff. That indicates the NAME, recent on 23-year-old female, recent onset symptoms, significant step up in the right atrium, significant diastolic runoff. All those things indicates now flow way to. Now, which is the commonest level flow way drain? Okay. And why is it common on the left side? Why it is not common from the left side? Find out. Yeah, you know with the mic. That's the problem. You answer that question. Okay, yeah. I don't know whether the new generation people are seeing this. One of these very into. Yeah. What is this? Yeah. No, not the light. What is this intervention? Who is having the mic? Yeah. How this procedure is done with the devices? PDA. The PDA coil. What we used to do is get 2-3 coils depending upon the size of the PDA and tie it with a non-absorbable distributor and use a biopsy to deliver PDA device. Okay. Problem is to the last. Next question. Yeah.
Timer is ready.
Then we will go tomorrow. That's a nice one. Yeah, sir, for that.
Timer is ready.
Yes, sir.
What is the position of the heart? Is it normal or something like that? The heart shifted or pushed or moved or
But I'm not smaller one.
so now it's not normal, not very normal. Fibers come out on this, right? Then effect, somewhere this effect and this effect, right? Something. What is here? So what is the diagnosis? So thank you.
Lights.
Thank you so much for that word session. We'll have the long case now again. We're switching between the